There's something nobody ever told you about what happens inside your gut after 60 Ds, and it's not what your doctor calls constipation. Last week I had a patient come into my office, 74 years old, active, sharp, her whole life organized down to the minute. She had to chair a crow, then 2 hours in 11 days. She'd go to the bathroom, sit down, push, something would come out, but there was always that feeling that something had stayed behind, like a pressure that won't let go, like a blockage that no laxative on earth could move. Her primary care doctor had told her 3 times to drink more water and eat more fiber. 3 times. And 3 times her situation got worse because what she had wasn't ordinary constipation. It was something that has a name, a mechanism, a solution, and that 62% of the adults over 70 I see in my office never get explained to them correctly. What I'm about to show you in the next few minutes could change forever how you understand what happens to your gut after 60. And if you have an older person in your life who's been living with this feeling for weeks, stay until the end, because the information that does the most damage isn't the information that's missing. It's the information that's given wrong. My name is Andrew Bennett. I'm a specialist nurse with more than 14 years dedicated exclusively to intestinal and digestive care in patients over 60. I work in a geriatric gastroenterology unit, and in all that time, I've walked alongside hundreds of older people who came in with the exact same diagnosis written in their chart: chronic constipation. But when you sit down, listen, and ask the right questions, the questions that don't fit into a 10-minute appointment, you discover that behind that diagnosis is something completely different. I've reviewed hundreds of cases of fecal impaction. I've been with patients before and after disimpaction procedures. I've seen the consequences of months of the wrong treatment. And every time I review a new case, I ask myself the same thing. How long has this person been carrying this without anyone explaining to them exactly what it is? Let me show you now, from the beginning, in words you can actually understand. Your gut is not a passive tube. It's an active organ, with muscle, with nerves, with memory. When you're 35, that intestinal muscle has a contractility, a capacity to squeeze and relax, rhythmically to move its contents toward the exit, that works almost automatically. You go to the bathroom, the rectum fills, the nerves send the signal, the muscle pushes, and the contents come out. But after 60, 3 things change at the same time. And when all 3 line up, the system fails in a very specific way. First, intestinal motility. The speed at which your gut moves its contents drops by 30% to 40% compared to when you were 40. Not because you're sick, but because that's how intestinal smooth muscle ages. Second, the nerves that coordinate that movement, especially the myenteric plexus, the nerve network that lives inside the intestinal wall, gradually lose neuron density over the years. Fewer neurons, less signal, less coordination. Third, the rectal lining, the inner surface of the rectum, becomes less sensitive. That means the threshold for feeling that the rectum is full rises. Your gut can be full without you clearly feeling it. So what happens when these 3 things combine? The intestinal contents reach the rectum and sit there longer than normal. The gut absorbs the water from those contents, because that's what it does. It absorbs water constantly, and the stool gets harder, more compacted, sticking to the rectal walls like someone mixed dry clay into the inside of a pipe. This is not constipation. It's not a lack of fiber. It's not that you don't drink enough water. It's fecal impaction. It's a real mechanical blockage inside the rectum. And treating it like ordinary constipation not only doesn't work, in many cases it makes it worse. That's the villain of this video, not a pill, not a food. It's a mechanism nobody explained to you that has been happening inside your body for weeks or months while they told you to take Metamucil. Before we go on, I need to be very clear with you because this is real digestive health and the details matter more than you think. There are symptoms that mean you should stop this video right now and call your doctor or go to the ER today. If you have intense, constant abdominal pain that won't ease with any position, go today. If it's been more than 72 hours without passing anything, not even gas, and your belly looks swollen and hard, go today. If you see a significant amount of bright red blood along with your stool, go today. If you have a high fever combined with abdominal pain and you haven't had a bowel movement in days, go today. Those symptoms can point to a real bowel obstruction, a perforation, or a hemorrhage, situations that are far beyond what any video can handle. Now, if what you have looks more like this, a feeling of incomplete emptying that's lasted days or weeks, pressure in the rectum that never fully lets go, excessive straining to pass a small amount, or the sensation that something is blocking the exit no matter how hard you push, then this video was made with exactly you in mind. Keep watching. I want to tell you about Robert. Robert is 71. He worked at the county clerk's office for 34 years. The kind of man who shows up on time to everything, who keeps a planner, who never goes to a doctor without writing down his questions the night before. He came in referred by his primary care doctor with a simple diagnosis: chronic constipation. 3 lines in the report, no further detail. He'd had the same feeling for 4 months. He'd go to the bathroom every 2 or 3 days, pass something, but there was always that pressure left behind, like a closed fist inside the rectum that wouldn't open all the way. He'd tried 2 kinds of laxatives. He'd upped his fiber. He'd started walking more. Nothing. What worried him most, he told me looking at the table, not at me, like it was hard to say, was that he was starting to strain in a way that scared him. Andrew, there are moments when I feel like I'm going to blow something out inside from pushing so hard. That sentence changed everything. Because excessive straining on the toilet, what we call in clinical terms a prolonged Valsalva maneuver, in a patient over 70 with mild uncontrolled high blood pressure, is a combination that can raise intracranial pressure acutely. I'm not telling you this to scare you. I'm telling you because that's exactly the information Robert needed 4 months earlier, and nobody had given it to him. We did an exam and confirmed what I suspected: fecal impaction in the lower rectum, not constipation, a real mechanical blockage with hardened stool that no oral laxative was going to dissolve, because oral laxatives act higher up, not in a rectum that's already impacted. We started a specific protocol: retention enemas, topical softeners, correct positioning on the toilet, and a maintenance plan tailored to his reduced motility. 3 weeks later, Robert came back. He walked in different... I can't describe it any other way. Same man, but without that specific weight that people carry when they've spent months with something that bothers them and nobody quite fixes it. He told me, for the first time in months, I walked out of the bathroom feeling like I was done. That sentence, that simple sentence, is what everyone deserves to feel. Did your doctor or your pharmacist ever just tell you eat more fiber and drink more water when you told them about this problem? Write it in the comments. I want to know how many of you got exactly that answer and whether it worked or not. Now I'm going to give you fratimai, 5 specific, interventions. These aren't generic tips. They're protocols with a mechanism, with concrete instructions, and with clear warnings about who shouldn't use them. Pick one. Start there. Your aging gut doesn't need 5 changes at once. First, evacuation positioning with a footrest. I know what you're thinking. Andrew, you're telling me how to sit on the toilet. I already know that. Hear me out for a second, because here the mechanism changes everything. The anorectal angle, the angle between the rectum and the anal canal. When you're sitting on a standard toilet is roughly 90 degrees. That angle creates a kind of kink in the system. The puborectalis muscle, which wraps around the rectum like a sling, keeps that kink closed to stop you from losing bowel control the rest of the day. Good. Useful. But at the moment of emptying, that muscle needs to relax so the angle can open. And with age, that muscular coordination becomes less precise. When you raise your feet onto a footrest of 7 to 10 inches, a step stool, a footstool, whatever you have, you change that anorectal angle to roughly 35 degrees. The canal straightens, the puborectalis muscle relaxes more completely, and the rectal contents have a more direct path out. The protocol is concrete. Place your feet on a firm support 7 to 10 inches high. Lean your torso slightly forward, about 35 degrees, elbows on your thighs. Don't push from the abdomen like you're lifting a heavy weight. Da derchitis, dat in der Valsalva maneuver. And in people over 65 with high blood pressure or heart problems, it can be dangerous. Instead, try a gentle low abdominal push, like you're inflating your belly out and down without closing your throat, without holding your breath. Important warning: if you have active or painful external hemorrhoids, check with someone before making this positional change, because opening the angle can increase local pressure in that area. The takeaway I want you to remember: posture isn't a detail, it's intestinal geometry, and geometry changes everything. Second, the retention enema with mineral oil at body temperature. This is where most people show up with the wrong idea. Hear me out. When there's real fecal impaction, redo panchet inertia coins, hardened stool stuck to the rectal wall, an oral laxative doesn't reach the problem. The laxative acts in the small intestine and the ascending and transverse colon. By the time the effect reaches the rectum, it's already passed over the blockage. It's like trying to clear a clogged pipe from the wrong end. Mineral oil delivered directly into the rectum works by a different mechanism. It doesn't stimulate peristalsis. It lubricates. It works its way between the hardened stool and the rectal lining, softens the fecal mass from the outside in, and reduces the stickiness between the stool and the wall. The protocol: use a small enema bulb of 4 to 5 ounces capacity, fill it with pharmaceutical-grade mineral oil at body temperature, around 97 to 99 degrees Fahrenheit. Not cold. Cold triggers a reflex contraction of the sphincter that makes it hard to hold in. Administer it lying on your left side, right knee bent up toward your chest. Hold the oil in for 15 to 20 minutes before trying to go. If you can hold it 30 minutes, even better. Warning: don't use enemas of any kind if you have active inflammatory bowel disease, recent anal fissures, or if you've had colorectal surgery in the last 3 months without explicit medical clearance. Takeaway: mineral oil doesn't cure the impaction in one shot. It's the first key, the one that starts to turn the lock. Third, timing your bathroom visits with the gastrocolic reflex. I know what you're thinking. Andrew, I go to the bathroom when I feel the urge, not when a nurse schedules it for me. Hear me out. The gastrocolic reflex is a real, measurable physiological response. When the stomach stretches as it receives food or liquid, it sends a signal through the enteric nervous system that increases colonic peristalsis. In young people, that reflex is strong and fast. It kicks in 15 to 30 minutes after eating. In adults over 65, that reflex still exists, but it's blunted, slower, weaker, but it's there. And if you take advantage of that window, that small wave of colonic activity that happens after eating, instead of going to the bathroom randomly, you multiply your chances of emptying with less effort. The protocol: sit on the toilet exactly 20 minutes after breakfast. Not lunch, not dinner. Breakfast produces the strongest gastrocolic reflex of the day because the colon has been at rest for hours. It doesn't matter whether you feel the urge or not. Sit down. Use the footrest from the first point. Wait 5 to 10 minutes. If nothing happens, get up without frustration. Repeat tomorrow at the same time. The gut brain, the enteric nervous system, works by habit. It learns schedules. In 58% of older patients with reduced motility who apply this protocol consistently for 14 days, the reflex becomes more predictable and more powerful. Warning: if you take cardiovascular medication that causes orthostatic hypotension, low blood pressure when you stand up, be careful getting up quickly from the toilet after straining. Stand up slowly. Wait a few seconds seated before getting to your feet. Takeaway: you're not waiting for the bathroom to happen. You're training your gut to know when it's its turn. Fourth, concentrating your hydration in the morning window. I know what you're thinking. Andrew, they already told me to drink more water. That doesn't work. Hear me out. Because here, the problem isn't the amount of water, it's the timing. The colon has a circadian behavior, its own biological rhythm that varies throughout the day. Colonic motor activity is significantly greater during the early morning hours, between 6 and 10 a.m. That's when the colon is most willing to move. If you spread your fluid intake evenly across the day, a glass here, another at midday, another in the afternoon, you never concentrate enough of a water stimulus in the window when the colon is most active. The protocol is specific. Between 6 and 8 a.m. before breakfast, drink 10 to 14 ounces of water, not cold, room temperature or slightly warm. Cold water can cause an esophageal spasm in some older people. Then eat breakfast. Then apply the gastrocolic reflex protocol from the previous point. The combination of a water stimulus plus a gastric stimulus plus the active circadian window is what produces the most consistent effect. Important warning: if you have heart failure or kidney failure with a fluid restriction prescribed by your doctor, don't change your fluid intake without checking with them. Hydration in those contexts has clinical limits this protocol cannot ignore. Takeaway: it's not how much water you drink, it's when you drink it. The colon has a schedule, and you can learn to line up with it. Fifth, descending abdominal massage in the direction of transit. I know what you're thinking. A massage? Seriously, hear me out. Abdominal colonic massage has existed in the specialized nursing literature since the 1980s, with accumulated evidence in geriatric populations showing reductions in intestinal transit time of 20% to 35% with consistent application. This is not an alternative medicine trick. It's a mechanical intervention on a muscular organ. The mechanism: external pressure on the abdominal wall activates mechanoreceptors in the intestinal wall, which stimulate the local peristaltic reflex. In simpler terms, you're pushing the intestinal contents in the right direction and telling the nerves in the wall that it's time to move.